So coming to the hypothalamus influence on the anterior pituitary. So all these above hormones are the hypothalamic hormones and they are influencing the anterior pituitary hormones, which finally will influence the organ system directly, or it will go to a specific gland, which we will see later. So first coming to the first one, it is called as growth hormone releasing hormone. This GHRH is releasing hormone. Then there is another hormone which is called as growth hormone inhibiting hormone. This growth hormone inhibiting hormone is also called as somatostatin. It is very, very important to remember this name. Somatostatin. Somatostatin is an universal inhibitor and growth hormone inhibitor is also a somatostatin. So what does it do? Both of them influences the production of growth hormone in the anterior pituitary. If it is a releasing hormone, it is going to stimulate it. If it is an inhibitory hormone, it is going to inhibit. Normally, the stimulatory effect is predominant. And coming to the next hormone that is produced from the anterior pituitary is prolactin. Prolactin. This prolactin is also under the influence of hypothalamus via two hormones. Prolactin releasing hormone. So what it is going to do? It is going to stimulate it. And there is prolactin inhibiting hormone. It is going to inhibit the production of prolactin. Out of this, which is dominant? The prolactin inhibiting hormone is dominant. Just we have to remember this very nicely. Prolactin inhibiting hormone is dominant over prolactin stimulating hormone. This prolactin inhibiting hormone is also called as dopamine. It is nothing but dopamine. Dopamine is being produced and it is constantly inhibiting the prolactin. Why it should be dominant? Because without pregnancy, there is no need for the milk production. So only during pregnancy, this dopamine will be suppressed and postpartum, the milk production will be increased. Other than that, there is no need for production of milk. So this dopamine is keeping it inhibited always, most of the time. So coming to the next hormone, that is GnRH. GnRH is gonadotropin releasing hormone. This is gonadotropin because it is going to act on the gonads. Gonadotropin releasing hormone. What it does, it's influencing the FSH and LH in a positive manner. It is stimulatory. Then there are two other hormones. So basically we will be discussing this growth hormone, prolactin, FSH and LH under anterior pituitary. But the last two hormones, they have their actions in a specific gland. So we will be discussing in the gland. This is the thyroid releasing hormone. It will produce TSH, which in turn will go and act in the thyroid gland. So we will be discussing them along with the thyroid gland. Then this is corticotropin releasing hormone. What does it do? It goes to the adrenals and produces, it goes to the pituitary to produce adrenocorticotropic hormone, which in turn goes to the adrenal for its final action. So these two will be discussed along with their glands. So coming first to the discussion of first anterior pituitary hormone, it is the growth hormone. But before this, there is one clinically important aspect. What happens whenever there is a lesion in between the hypothalamus and pituitary? Tell me. Whenever there is a lesion between hypothalamus and pituitary, all of us think all the hormones of pituitary should be reduced. But there is some exception, and exceptions are always as in the exams. Why is that exception is? Because I said prolactin inhibitory hormone is predominant normally. So, but if it is cut, what will happen to the prolactin level? This hypothalamo-hypophyseal tract lesion will reduce all hormones, all anterior pituitary hormones, except this exception is a question, that is prolactin. This prolactin is kept under inhibition, but right now because of the injury, the prolactin will be produced, and this will produce a symptom also, which is galactorrhea. It is producing galactorrhea. Galactorrhea means excessive milk production. So galactorrhea is being produced. So that is an exception. Prolactin will be increased in case of a lesion in between hypothalamus and pituitary. Now coming to the anterior pituitary hormone, that is the growth hormone. We are starting with growth hormone. Growth hormone has different actions. It has direct actions also and indirect actions also. Direct action means the growth hormone is produced and directly it will act on the cells of the body. So the direct action of growth hormone is nothing but increase in growth of the person, and it is anti-insulin. It acts against the insulin. It is anti-insulin and it will cause lipolysis, and it helps in growth of pre-chondrocyte to the chondrocyte. Pre-chondrocyte will be converted to the chondrocyte. Then coming to the indirect actions. Indirectly, what it does do? Indirectly, it first goes to the liver and produces two substances like insulin growth factor 1 and insulin like growth factor 2. This IGF is nothing but insulin-like growth factor. So whenever it is producing this substance, what will happen? It is opposite of it. It is the insulin actions. It is like acting like an insulin. Second thing is it is converting the chondrocyte to the mature bone. So first pre-chondrocyte will be converted to chondrocyte by direct action, and final maturation will be done like an indirect action with the help of insulin-like growth factor. We should note one very important thing. What hormone is responsible for the fetal growth? The fetus inside the mother is growing nicely, but which hormone is most essential? Most of us think it is the growth hormone. So that is why it's a wrong answer. The correct answer is thyroid hormone. For a fetal growth, thyroid hormone is more essential than that of a growth hormone. So this is an MCQ. Then coming to the growth hormone stimulators and inhibitors. Growth hormone can be stimulated by exercise. All of us know why. That's why they advise people to exercise so that they can increase their growth right from the childhood. Then hypoglycemia, starvation. Any kind of stress will increase the growth hormone. So hypoglycemia and starvation. And one part of the sleep, that is non-rapid eye movement sleep, will increase the growth. So a good sleep with non-REM is also very, very essential for the stimulation of growth hormone. And it is inhibited by, if NREM comes this side, then REM sleep, that is a rapid eye movement sleep, will inhibit it. Then another one which inhibits it is the glucose. If there is excessive glucose, growth hormone will be inhibited. So these are the stimulatory and inhibitory factors of growth hormone. Now coming to the disorders of growth hormone. Disorders of growth hormone is very important. Disorders of growth hormone, there can be a decrease also, there can be an increase also. So we are going to discuss two decrease conditions and two increase conditions. First, coming to the decrease conditions. There can be a direct deficiency of growth hormone. Growth hormone itself is deficient. What will happen? The person will be short. That is called as dwarfism. This is called as dwarfism. So there is specific drug given for this, and that has been asked in MCQs, that is sermorelin. It is a growth hormone stimulator. So this drug can be given for the dwarf patients. And there can be a decrease in growth hormone receptors. Here the problem is not with the growth hormone. There is a decrease in growth hormone receptor. There also will be dwarf, but it is specifically called as Laron dwarfism. Laron dwarfism. So how will be the history? In the history of the patient, they will say the growth hormone levels are normal, or sometimes because of the non-receptors, their levels can be increased also. The growth hormone levels are increased, but still the person is have dwarf. The only option for that is the Laron dwarfism, because it is a receptor level problem. There is growth hormone, but it is not going to go and act on it. Then coming to the increased conditions. Increased condition can happen right from childhood or suddenly in an adult age. Suddenly in adult age, usually due to any kind of tumor. So childhood, if it is increased, then it is called as gigantism. Whereas in adulthood, if it increases, A for A, it is acromegaly. It is acromegaly. So what is the difference between them? Because both can be asked in questions. What is in gigantism? What happens is there is an increased growth, but this growth is usually increased proportionately. Why proportionately? Because right from childhood there is an increase in growth hormone. But what happens in an adult? There is increased growth, but most of the bones are fused already in the body. So there will not be an increase proportionately. So there is disproportionate. There is a disproportionate increase in the growth of the person. And this will have a classical history like prominent jawbone. Prominent jawbone, which is called as prognathism. Prognathism. So this can be the classical history for this kind of acromegaly. And they will show you an adult picture where it is having a prominent jawline like this. Then coming to the treatment for this. Treatment for this is already growth is happening too much, so we have to stop it. Who can stop it? The somatostatin can stop it. So the treatment for both types of deficiencies. For an acromegaly, if it is due to a tumor, just we have to remove the tumor. But the drug treatment will be octreotide. What is this octreotide? This octreotide is nothing but a somatostatin. Because somatostatin is the one which is like acting like a growth hormone inhibiting hormone. So growth hormone inhibiting hormone from the hypothalamus. So we have to just give the octreotide. And they will ask you the difference between a pituitary dwarfism and thyroid dwarfism. Even in thyroid disorder, I said thyroid is required for the growth, so it is also having a dwarfism. Whereas in case of pituitary dwarfism, what is the function is there is decreased growth hormone, that is easily understandable. Second thing is there is overall growth retardation. There is an overall growth retardation which is happening. Whereas in case of thyroid dwarfism, the infantile features are preserved. This is the important clue for us. The infantile features. If they give a dwarf child with picture where it is having a pot belly and looking like an infant itself, that is a clue for a infantile thyroidism or a thyroid dwarfism. So this is the important clue for us. They will give you a pot belly picture of a child which is having a pot belly, because the infants, they usually have a pot belly and their muscle mass is more on the abdominal side. So this kind of feature stays in case of thyroid dwarf, whereas in case of pituitary dwarf it is not seen. Now coming to the second hormone in the anterior pituitary, that is prolactin. Prolactin is very similar to that of the growth hormone. Most of its function are similar to that of the growth hormone, but it has one very specific function, prolactin. That's why they have named it. It is helpful in milk production. So there are two terms. Production of milk is by the prolactin, whereas milk ejection, just to revise, milk ejection is by oxytocin. Whenever they ask milk ejection, milk letdown reflex, all of them is by the oxytocin. But milk is already produced by some hormone, that is the prolactin. We saw whenever there is a hypothalamus and pituitary section or a lesion, only prolactin is increased. But there is another disease where there is pituitary hypoperfusion. Immediately after postpartum, what happens is some pituitary hypoperfusion can happen. Because the pituitary is usually enlarged during pregnancy, in the postpartum, what will happen? This enlarged pituitary is not being able to be supplied by the vessels that is present. So what will happen? There will be a pituitary hemorrhage postpartum. If the pituitary is directly affected, what will happen? All hormones are reduced. Here there is no exception because there is a direct attack on the pituitary itself. All hormones are reduced, including which hormone? One exception we saw, that is prolactin. Here it is also reduced, including prolactin. And this could be one of the reasons where the mother is not able to breastfeed the baby. If it is a severe form, then it is very dangerous. But milder forms can be there where the mother is not able to feed the baby because prolactin itself is reduced in these conditions. And there is a specific name for this syndrome, which is called as Sheehan syndrome. Now coming to the next two hormones, that is the FSH and LH. Both of them are stimulated by the gonadotropin releasing hormone from the hypothalamus. So they are going to produce FSH and LH in the pituitary. These hormones, they have their actions both in males and females. That's why we have written it separately. So follicular stimulating hormone, what will be its function? It is going to stimulate the ovarian follicles. In a female, it is going to stimulate the ovarian follicles. It is easy to understand. What is the function of LH in case of a female? There is stimulation of follicles by the FSH, but maturation happens with the help of LH. And all of us know one function of LH, which is also a positive feedback, and that is ovulation. Ovulation also happens because of the presence of LH surge. Ovulation happens because of LH surge. Then the corpus luteum survival. In case before the development of placenta, the corpus luteum is the one which is sustaining the embryo. So that is also done with the help of LH. LH should be adequately present to sustain the corpus luteum. Then coming to the functions in males, follicle stimulating hormone, S, will act on the S, that is Sertoli cell development. Sertoli cell is we will discuss more in detail about Sertoli cell, but it is like a nursing cell. It is like a nursing cell for the Leydig cells. Leydig cells is the one which is going to produce the testosterone. So LH, where does it act? L for L, Leydig cells, it will act and produces the testosterone. This Sertoli cell usually nourishes this Leydig cells for the production of testosterone. So coming to another syndrome where there is reduction of this particular two hormones, that is FSH and LH. And along with that, there is anosmia also. The hypopituitarism is there, pituitary is not functioning properly, and anosmia. Especially the FSH and LH are decreased. So that syndrome is called as Kallmann syndrome. When they give a history of hypopituitarism along with anosmia, there is only one disease which is Kallmann syndrome. So this is all about our pituitary.